When we talk about the anterior abdominal wall, we must remember that uh, anterior abdominal wall is hexagonal in shape, and it starts from the xiphoid process cranially, which is the midline under the sternum, and it extends laterally downwards along the costal margin where it meets the lateral abdominal wall, and then again comes down obliquely in the medial to the medial point just above the pubis along the iliac crests and the inguinal ligament. So therefore, this area is hexagonal, and it is bounded, like I said, superiorly by the xiphoid process and the costal margins, and inferiorly by the iliac crests, the superior edge of the pubic bone, and the inguinal ligament stretching in between. Now, laterally, it also extends along the flanks posteriorly, where there is the lateral border of the erector spinae and the quadratus lumborum, and the inferior border of the 12th rib. So anteriorly, it is hexagonal, and as it curves around the flanks, it extends posteriorly as well. Now, the important thing again about the anatomy of the anterior abdominal wall is that there are no bony structures other than the borders, which are giving rise to the muscles that form the anterior abdominal wall. So therefore, the anterior abdominal wall is purely musculo-aponeurotic, and it has a very important function. These flat muscles of the anterior abdominal wall help in stabilizing the spine, help in the erect posture, help in increasing the intra-abdominal pressure, and thereby assist in defecation and urination, and also by elevating the diaphragm, increasing the intrathoracic pressure, and aiding in cuffing. Like I said, the flexion, extension, rotation, and stabilization of the spine on the hips, on the pelvis, is also aided by these muscles. These muscles also act as, in absence of any bony structure, also act as the protective mechanism for the underlying viscera. So all the intra-abdominal viscera is protected from the external influences by these flat muscles of the abdominal wall. Now, these abdominal wall muscles can be further subdivided into two variable groups. So if we look at these groups, there is the midline group, and then there is a lateral group. So the midline group runs in the midline on either side of the midline, and you know that this is comprised by the rectus abdominis muscle, which is again a paired muscle which runs from the pubis inferiorly to the xiphoid and the lower ribs superiorly. And there is a small paired inconsistent muscle which is present inferiorly, which is known as a pyramidalis muscle. The lateral group of muscles is formed by the three paired muscles on either side. From the most superficial to the most deep, these are the external oblique muscle, the internal oblique muscle, and the transversus abdominis muscle. Now, all these muscles, the two midline muscles, the two pairs of midline muscles, and the three pair of lateral muscles are there then covered by the subcutaneous fat and the skin. So we'll quickly talk about each of these muscles. So the rectus abdominis, like I said, is the main muscle which is comprising the midline group, and it is a face in the midline and the anterior surface of 5th to 7th costal cartilages. The anterior surface of rectus abdominis has variable 3 to 4 transverse tendinous bands which act as a point of insertion of or stabilization of this muscle, by way of which this muscle inserts into the anterior rectus sheath and thereby gets segmented into smaller components. The blood supply of the rectus abdominis is by paired superior epigastric and the deep inferior epigastric arteries, of which the deep inferior epigastric arteries are seen very frequently while performing the inguinal hernia repairs, both open as well as laparoscopic. The rectus muscle is supplied by the ventral rami of 6th and 7th, starting from T6, 7 to L1 intercostal muscles. As they emerge from the spinal canals, curve laterally, and then emerge anteriorly. The ventral rami supply the rectus abdominis muscle. And because it is present in the midline, it is the primary muscle which is responsible for flexion of the abdominal wall. So you can easily understand when this anterior muscle contracts, it will bend the spine anteriorly and thereby aid in flexion of the abdominal wall. Also, like other the flat muscles of the abdominal wall, it helps in increasing the intra-abdominal pressure. The other midline muscle, which I said is inconsistent. Why is it inconsistent? Because it can be absent in as many as 70% of the population on either one or both the sides. It is a smaller muscle which is present only in the inferior part, and it is a triangular muscle, and it lies between the anterior surface of the rectus abdominis and the anterior sheath. Now, it originates caudally from the pubic crest. So these are the small pyramidalis muscles. They originate inferiorly from the pubic crest and insert into the linea alba. The function of this inconsistent muscle is not well understood, and therefore it is not of a very important clinical significance. Now we come on to the lateral muscles, of which the most superficial is the external oblique muscle. And you can see the external oblique muscle starts from the external surface of the 5th to 12th ribs and runs in a direction which is downwards, forwards, and medially. So in the anatomy classes, the direction of the fibers is classically taught as the direction of your fingers when your hands are in the trousers. So in the pockets of your trousers. So when your hands are in the pockets of your trousers, your fingers are directed forwards, downwards, and medially. And likewise is the direction of the fibers of these muscles. They insert along the outer lip of the iliac crest and then at the lateral part of the inguinal ligament as well. Now, as the muscle traverses medially, the muscular fibers get converted into aponeurosis, and this aponeurotic part of the external oblique contributes majorly to the formation of the anterior rectus sheath, which is the anterior lining of the rectus abdominis muscle. It also, the lower incurved part of the external oblique also between the ASIS and the pubic tubercle forms the inguinal ligament, and an aperture within the inguinal ligament through which the spermatic cord emerges out to traverse into the scrotum is known as a superficial inguinal ring. The vascular supply is from the intercostal arteries and the deep muscular branches of the deep circumflex iliac artery. And the nerve supply is from basically the nerves which are supplying the rectus abdominis, that is from T6, T7 to L1. The function is to provide compression for the visceral sac because it is a lateral muscle, it is a flat muscle. So when it contracts, it provides compression to the peritoneal cavity and also provides protection to the peritoneal cavity. And because it is a laterally placed muscle, so like the rectus was present in the center, so when it contracted, it causes flexion. This is present laterally. So when the lateral muscle of one side contracts, it will cause flexion of the spine onto that side. And both the muscles acting synergistically will cause, so one external oblique and one internal oblique of the opposite side, when they contract synergistically, they will stabilize the muscle. Next, we come on to the internal oblique muscle, which is the muscle which is present in the middle between the external oblique and the transversus abdominis. So the internal oblique, direction of the internal oblique is perpendicular to the fibers or direction of the fibers of the external oblique. So whereas the fibers of the external oblique run downwards, forwards, and medially, the fibers of the internal oblique, they arise inferiorly from the anterior leaflet of the thoracolumbar fascia, the iliac crest, and the lateral half of the inguinal ligament, and then run upwards and medially. They insert along the inferior border of the 10th to 12th ribs and then onto the linea alba. The lowest most fibers of the internal oblique muscle gives rise to loops of fibers which go around the spermatic cord and are known as cremastric fibers. The lower part of the internal oblique which becomes aponeurotic, tendino-aponeurotic, also merges with the tendino-aponeurotic part of the transversus abdominis to form the conjoint muscle or the conjoint tendon, which then goes on to insert onto the pectineal line of the pecten pubis. Now, the medial insertion of the uh, internal oblique, so it is very peculiar that it also becomes aponeurotic as it goes medially, just like the external oblique muscle. So whereas the external oblique aponeurosis solely gives rise to the formation of the anterior rectus sheath, the aponeurosis of the internal oblique is unique that above the level of the arcuate line, it splits into two, and the anterior component goes along with the aponeurosis of the external oblique to form the anterior rectus sheath. The posterior lamina goes along with the aponeurosis of the transversus abdominis to form the posterior rectus sheath. Caudal to the arcuate line, we'll talk about what is arcuate line. Caudal to the arcuate line, which is midway between the umbilicus and the pubic symphysis. The whole of the aponeurosis of the internal oblique goes anteriorly and gives rise to the formation of the anterior rectus sheath, and none of it goes behind to form the posterior rectus sheath. It is supplied by iliohypogastric nerve and the ilioinguinal nerve, and it functions synergistically with the transverse abdominis muscle. It also, like I said, works in tandem with the contralateral external oblique muscle to cause ipsilateral rotation and torsion of the trunk and stabilization of the trunk. The deepest muscle of the three flat lateral muscles of the abdominal wall is the transversus abdominis muscle, which, like the name suggests, has the fibers which are running transversely. So external oblique runs downwards, forwards, and medially. Internal oblique runs upwards and medially, and transversus abdominis runs transversely. Now, it originates from the inner surfaces of the 7th through 12th costal cartilage cranially, then the anterior leaflet of the thoracolumbar fascia in the midline, and a part of the iliac crest and the lateral third of the inguinal ligament. So it has a wide origin and it runs medially to insert onto the linea alba. Now, just like the external oblique, it is the main component, because it is the deepest muscle, it is the main component which gives origin to the posterior rectus sheath. But this arrangement is only present till the arcuate line, which is present, like I said, somewhere between the umbilicus and the pubic symphysis. So what happens? The aponeurotic part of the transverse abdominis goes posteriorly to form the posterior rectus sheath above the level of the arcuate line, and below the level of the arcuate line, it runs above or superficial to the anterior rectus sheath, comes anterior to the rectus muscle to form the anterior rectus sheath. So, like we learnt in the internal oblique muscle, the transversus abdominis joins the lower part of the internal oblique to form the conjoint tendon, which then inserts onto the pubic crest. So this is the arrangement of the aponeurotic part of these muscles as they go medially and give rise to the anterior and the posterior rectus sheath. The most superficial, which is labeled as 1, is the external oblique. The middle one is the internal oblique, which is labeled 2. And the deepest one is the transversus abdominis, which is labeled 3. The midline muscle is the rectus abdominis. Now you can see above the level of the umbilicus, or above the level of the arcuate line, the aponeurosis of external oblique gives rise to the anterior rectus sheath. The aponeurosis of the internal oblique splits into an anterior leaflet, joining the external oblique aponeurosis to form the anterior rectus sheath, and a posterior leaflet which joins the aponeurosis of the transversus abdominis to form the posterior rectus sheath. And the aponeurosis of the transversus abdominis solely forms the posterior rectus sheath. Now, below the level of the arcuate line, the aponeurosis of all these three muscles, that is the external oblique, the internal oblique, and the transversus abdominis, run anterior to the rectus muscle, and all three of these will give rise to the anterior rectus sheath. And because none of these three muscles are going posterior to the rectus, so therefore the posterior rectus sheath is devoid below the level of the arcuate line. The blood supply of transversus abdominis is the same as the rest of the two muscles, that is external oblique and the internal oblique. The innervation is from the ventral rami of T6-7 to L1, and uh, they the vascular supplies again from the intercostal muscles and the deep muscular branches of the inferior epigastric muscles. Now, the important thing to remember is that there is a very important plane between the transversus abdominis muscle and the internal oblique muscle, which is known as the transversus abdominis plane. It is the plane in which all the intercostal nerves are coursing as they emerge from the ventral rami, and before they pierce the internal oblique muscle and become more superficial to innervate the rectus abdominis muscle. So it is this plane in which the transverse abdominis plane blocks are given. So if you want to give tap block, you have to introduce the local anesthetic agent in between the plane which is present between the transverse abdominis muscle and the internal oblique muscle, because all the nerves of this region are running in this plane. Now, the transversus abdominis muscle has a very significant function in the abdominal wall, and along with internal oblique muscle, it forms a kind of a wrap around along the visceral sac, providing rigidity to the anterior abdominal wall. And because both the internal oblique and the transversus abdominis muscles are attached posteriorly to the thoracolumbar fascia, when they contract, they create tension in this fascia and provides posterior support to the visceral sac. So the anterior support is provided by these flat muscles, and the posterior support between the lateral border of the erector spinae and the quadratus lumborum and the thoracolumbar fascia is provided when these muscles contract and in turn make the thoracolumbar fascia tense. The midline structure, which is a fascio-aponeurotic structure, is the linea alba. It is known as a white line. So linea is line and alba is white. And it is a fibrous structure which is composed of collagen and elastin. And it is formed by the merging of the anterior and the posterior rectus sheaths. So you can see the on the lateral border of the rectus muscle, the two sheaths are separate. The one which is going anterior to the rectus sheath is the anterior rectus sheath. The one which is going posterior to the rectus sheath is the posterior rectus sheath. And again, on the medial border of the rectus sheath, these two come together and join. And when the two join on either side of the midline, they form the linea alba. And because it is present in the midline, on either side are the two rectus, it seems as if it is bisecting the paired rectus abdominis muscles running on either side longitudinally. Now, because it is a relatively avascular plane, it is a preferred location for the midline incisions for intra-abdominal access, like in laparotomies. It is also the site of majority of primary ventral hernias and most incisional hernias, because most of the incisions are given through the linea alba. So it is obvious that most of the incisional hernias will also arise through the linea alba incision. Also because the fibers are mainly elastin and collagen, and they are arranged in a crisscross manner. So there are small defects which are present in between through which the nerves and the vessels pass. And because of the continuous increase in the intra-abdominal pressure, sometimes these defects enlarge and the extraperitoneal fat or the preperitoneal fat emerges out and forms a ventral hernia in the form of epigastric hernia or the paraumbilical hernia. So most de novo ventral hernias arise from the linea alba. So again, let us see at a cross section of the abdominal wall. So the midline structure, that white structure that you see intersected by the umbilicus, is the linea alba. On either side is the rectus abdominis. So the upper part of the rectus abdominis is cut here. Anterior to the rectus abdominis is the anterior rectus sheath, and posterior to the rectus abdominis is the posterior rectus sheath. This is the external oblique. You can see the fibers running is to the anterior rectus sheath. Deep to the the external oblique muscle is the internal oblique muscle, which has the fibers running perpendicular to the external oblique muscle, and its aponeurosis splits into two. The anterior component forms the anterior rectus sheath, the posterior component forming the posterior rectus sheath. And the deepest muscle the lateral muscle is the transversus abdominis with transversely running fibers, with whose aponeurosis gives rise to the formation of the posterior rectus sheath. Now, what is the arcuate line? So, arcuate line is the line at which the posterior rectus sheath stops. So, we have seen this arrangement that somewhere between the umbilicus and the pubic symphysis, all the three aponeuroses, the aponeurosis of all the three muscles, the external oblique, the internal oblique, and the transversus abdominis, go anterior to the rectus and none go posterior to the rectus. So therefore, the posterior rectus sheath is deficient. This inferior border of the posterior rectus sheath, beyond which the posterior rectus sheath is deficient, is known as the arcuate line. It is generally located halfway between the umbilicus and the pubic symphysis, but there is a variation from person to person. And inferior to this, all the three flat muscles pass anterior to the rectus muscle, and therefore the rectus, the belly of the rectus, is in direct contact between the transversalis fascia and the peritoneum. Now, this is a very important and a very unique anatomical arrangement, which suits the surgeons excellently because it gives us a very unique area to access the pre-peritoneal space. Because all we have to do is go between the posterior rectus sheath and the rectus abdominis, create that plane and pass beyond the arcuate line. And there, the only thing that remains behind the rectus abdominis is the fascia transversalis and the peritoneum. And there you are in the pre-peritoneal plane, which is the plane that you dissect for the totally extraperitoneal repairs, the TEP. Now, it is also, the arcuate line is also the location for Spigelian hernias, and it is also the landmark where the inferior epigastric vessels perforate the rectus abdominis to supply them. Now, along with these flat muscles, we must also talk about two important extraperitoneal spaces, which we talked about earlier when we learned about the laparoscopic repair of inguinal hernia, TEP, when the ETEP. The midline space between the pubic symphysis and the bladder, which is a retropubic space, is known as a space of Retzius. And the lateral space, lateral to the space of Retzius, which is deep to the inguinal ligament, is known as a space of Bogros. The space of Bogros, in turn, has a medial compartment and a lateral compartment. The medial compartment is nothing but same as the triangle of Doom, which houses the femoral vessels. And the lateral compartment is nothing but the triangle of pain, which is the part where all the muscles and the nerves pass from the pelvis down to the thigh. So what are the different points of weakness? If we look at the abdominal wall from the inside, so this is the inside out view, there can be a defect in the linea alba between the umbilicus and the xiphisternum, through which a hernia can emerge, and this hernia is known as an epigastric hernia. Then there can be a defect in the region of the umbilicus, through which if the hernia emerges out, it is known as an umbilical or a paraumbilical hernia. And then there can be a defect at the level of the arcuate line laterally, where if a hernia emerges out, it is known as a Spigelian hernia. Now, again, a cutout, which just to recapitulate the anatomy, the anterior rectus sheath, the rectus abdominis, then the external oblique, the internal oblique, the transversus abdominis, and this is the pyramidalis muscle. That is the lower aponeurotic part of the external oblique forming the inguinal ligament, and an aperture in the external oblique aponeurosis close to the pubic tubercle, that is a superficial inguinal ring. Now, if you look at the cross section, I am sure you would remember this cross section that you drew during your anatomy classes in your MBBS. So that is the posterior midline. These are the psoas muscles on either side, the rectus spinae and the quadratus lumborum. Then the different layers of the thoracolumbar fascia, that is the peritoneum, the visceral and the parietal peritoneum, and the thoracolumbar fascia giving rise to the fascia transversalis anteriorly. The pink muscle, the muscle which has been drawn in the pink is the transversus abdominis. The one which is drawn in red is internal oblique, and the one which is drawn in purple is the external oblique. External oblique aponeurosis forming the anterior rectus sheath, internal oblique splitting into an anterior and a posterior leaflet, forming the anterior and the posterior rectus sheaths respectively, and the transversus abdominis aponeurosis forming the posterior rectus sheath. So why are we so intent on learning these different planes between the muscles and the fascia? Because these are the planes which we as surgeons exploit to place the meshes during the ventral hernia repair. So what are the different planes in which we can place the mesh during a ventral hernia repair? So if the mesh is placed over the anterior rectus sheath deep to the subcutaneous tissue, it is known as an onlay repair. It is usually done in open repairs. The most common type of open ventral or incisional hernia repair is a onlay repair. If the mesh is placed in between the two rectus abdominis muscles as a bridging repair, it is known as an inlay repair. It is a very uncommonly performed repair. If the mesh is placed between the rectus abdominis and the posterior rectus sheath, it is known as a retrorectus sublay repair or a retromuscular sublay repair because it is behind the muscle. If the mesh is placed between the posterior rectus sheath and the peritoneal cavity, it is also a sublay repair, but it is not a retrorectus or a retromuscular repair. So it is known as a preperitoneal sublay repair. And if the mesh is placed inside the peritoneal cavity, it is a sublay intraperitoneal repair. Or if you look at it from the inside out, then it is known as an intraperitoneal onlay repair. Now, what are the different types of repairs that are done laparoscopically? So it can be a subcutaneous onlay. It can be an enhanced view, totally extraperitoneal Reeve Stopa repair, transabdominal retromuscular repair, transabdominal retromuscular umbilical hernia repair, endoscopic mini or less open sublay, totally endoscopic sublay, then transabdominal preperitoneal, preperitoneal enhanced view, TEP repair, intraperitoneal onlay with or without defect closure, then endoscopic assisted linea alba reconstruction, laparoscopic intracorporeal rectus aponeuroplasty, and pre-aponeurotic endoscopic repair. So there are so many acronyms and so many repairs, which tells you that none of the repair is perfect for all the patients. And you have to tailor the repair according to the patient that you get. Now, combining the last two slides, one in which we learned about the different planes in which we place the mesh, and one in which we learned about the different laparoscopic repairs that we do. What are the different repairs and their planes in which the meshes are placed? So for onlay, I told you the open version is the open onlay and the laparoscopic version is a scola, subcutaneous onlay. Inlay, I told you that is a uncommonly done repair, so we are not going to talk about it. For the retrorectus sublay, the open version is the open retrorectus or Reeve Stopa repair. The laparoscopic version is ETEP RS, transabdominal retromuscular repair, transabdominal repair of umbilical, TARUP, or EMILOS, or the totally endoscopic repair. Then totally extraperitoneal sublay repair. If we talk about the plane that is present between the posterior rectus sheath and the peritoneum, that is the preperitoneal sublay, the laparoscopic counterpart is transabdominal preperitoneal for ventral hernia, or the preperitoneal enhanced view totally extraperitoneal repair, which is a new repair which has been recently described. And if we talk about the intraperitoneal repair, then we have the intraperitoneal onlay mesh repair with or without defect closure, which is known as IPOM or IPOM plus respectively. Now, a word about the anatomy of the transversus abdominis release or the posterior component separation operation, which is known as a TAR. So this concept was was possible because of the fact that the transversus abdominis muscle and the posterior lamina of the internal oblique aponeurosis, both of these give rise to the posterior rectus sheath. And if we divide this insertion of the posterior lamina of the internal oblique and the transversus abdominis aponeurosis, we can release the peritoneum posterior rectus sheath component from the flat muscles and thereby aid in medialization of the posterior rectus sheath along with the peritoneum in situations where otherwise closure of the peritoneum or the posterior rectus sheath would not be possible without tension. So therefore, this operation or this procedure aids the medialization of the posterior rectus sheath peritoneum complex and thereby helps in closure and reinforcement of the posterior component, thereby closing the visceral sac in complicated hernias where there is loss of domain. And then a mesh can be placed in the same plane where a plane can be created between the fascia transversalis peritoneum complex and the transversus abdominis muscle. The neurovascular bundles, mind you, run between the transversus abdominis and the internal oblique. So they are safeguarded. They don't have any danger of getting injured. You are dissecting between the transversus abdominis and the fascia transversalis. And what is the posterior limit of this plane? So if I go back to this diagram, the posterior limit of this plane is all the way to the psoas and the quadratus lumborum. So a large mesh starting from the midline going all the way to the psoas and the quadratus lumborum can be placed on either side, thereby buttressing uh, the defect and augmenting the repair. So this is the plane in which the mesh after a transversus abdominis repair is finally placed.